Welcome to SLP Nerdcast. I'm Kate.
And I'm Amy, and we appreciate you tuning in. In our podcast, we review and provide commentary on resources, literature, and we discuss issues related to the field of speech-language pathology.
You can use this podcast for ASHA CEUs. Visit our website for other courses, including live courses, webinars, blog posts, and SLP Masterclasses available for graduate level credit. SLP Nerdcast is committed to improving continuing education in our field through affordable pricing and open access libraries. You can support our work by leaving a review, referring a friend, making a one-time contribution on our website, or subscribing. You can subscribe for as low as $7 a month and get access to monthly Q&A sessions, exclusive content, discounts, and a resource library of downloads, freebies, and printables. Want unlimited access to ASHA CEU courses? There's an affordable subscription for that too. For more information, visit us on our website or contact us anytime on Facebook, Instagram, or at info@slpnerdcast.com. We love hearing from our listeners, and we can't wait to connect with you.
And just a quick disclaimer, the contents of this episode are not meant to replace clinical advice. SLP Nerdcast, its hosts, and guests do not represent or endorse specific products or procedures mentioned during our episodes unless otherwise stated. We are not PhDs, but we do research our material. We do our best to provide a thorough review and a fair representation of each topic that we tackle. That being said, it's always likely that there's an article that we've missed or another perspective that we haven't shared. If you have something to add to the conversation, please email us. We love hearing from our listeners.
This episode is brought to you in part by listeners like you and one of our amazing corporate sponsors, MedTravelers. MedTravelers is your industry leader for exclusive allied healthcare travel opportunities. MedTravelers has benefits like higher earning potential, W-2 employee status, and a flexible schedule. Visit medtravelers.com to learn more. MedTravelers did not participate in creating the contents of this episode. We're so excited for today. We get to welcome back a repeat guest that we always have so much fun with. Welcome, Natalie Douglas.
Hello. I'm so excited to talk with you again.
The last time that you were here, I think we had a moment where one of us screamed scurvy, which was like the most fun I think we have had on this podcast. Maybe not the most, but it was up there. It was great. So I can't wait to hear what you're going to teach us today, aside from scurvy.
I think outside of scurvy, it sounds like you're going to talk to us a bit about communication and life participation, which we're super looking forward to.
Yes.
Before we get started, and for our listeners who haven't met you before, can you tell us a little bit about yourself?
Sure. So I am Natalie Douglas. I'm on the faculty at Central Michigan University. I'm also an editor at the Informed SLP, and my biggest interest is in trying to merge the gap between research and practice through implementation science. Clinically, most of my work now is in quality of life and communication interventions for people with dementia in long-term care environments. So sometimes that's assisted living, sometimes skilled nursing facility. I do have a bit of a clinical background. I worked for about 10 years in between master's and PhD in hospital settings, outpatient, a little bit of home health. So that's kind of me in a snapshot.
I love that you have that chunk of clinical experience prior to your doctorate. I know in a previous episode, you told us a lot of anecdotes about the real working conditions of a clinician and how the research to practice gap is so completely apparent when I believe your story was something like, why would you read an article when you can't even find a dry erase board marker for your patient and you're running around focused on that for 15 minutes, the life of the real working clinician and the barriers that we all face. So your perspective is always so unique, and we're really excited for you to teach us about this. And as our listeners know, we know very little about this.
And just a plug for our previous episodes on implementation science, which is a fascinating area of the field that I knew nothing about prior to having those conversations with you. And it's really interesting. And the idea of bridging that research to practice gap, I think is such a huge, important thing for us to know about as a field.
Definitely.
You're here. And we could get on a soapbox about that, but we won't. I'm going to redirect us over to our learning objectives. So before we get into all the fun stuff and before Natalie teaches us everything, I do need to read our learning objectives and disclosures. Objective number 1, describe elements of implementation practice that support training formal and informal care partners of people with dementia in techniques to support quality of life and communication. Learning objective number 2, discuss case studies highlighting evidence-based practice approaches to manage communication and life participation for a person with dementia. And learning objective number 3, summarize strategies to position SLPs as key members of the healthcare team within the skilled nursing facility. Disclosures, Dr. Natalie Douglas's financial disclosures. Dr. Douglas receives a salary from Central Michigan University and the Informed SLP. She also receives book royalties from Plural Publishing and has research funding from the American Speech Language Hearing Foundation. Dr. Douglas has no non-financial relationships to disclose. Kate, that's me. My financial disclosures, I'm the owner and founder of Grand Bois Therapy and Consulting, LLC, and co-founder of SLP Nerdcast. My non-financial disclosures, I'm a member of ASHA SIG 12 and serve on the AAC Advisory Group for Massachusetts Advocates for Children. I'm also a member of the Berkshire Association for Behavior Analysis and Therapy, Mass ABA, the Association for Behavior Analysis International, and the corresponding Speech Pathology and Applied Behavior Analysis Special Interest Group. Amy Wonka's financial disclosures. Amy is an employee of a public school system and co-founder of SLP Nerdcast. Amy's non-financial disclosures, she is a member of ASHA SIG 12 and serves on the AAC Advisory Group for Massachusetts Advocates for Children. Okay, we've made it through the boring stuff, on to the fun stuff. Natalie, can you start off by telling us a little bit about the first learning objective? What is the difference between informal and formal care partners? These are terms I have absolutely never heard before.
Right. So when it comes to terminology in the dementia community, there's a term of informal care partners and then formal. So informal would be someone, a family member. Typically what happens, if there's a couple and someone married or living with that person, they become the care partner or the caregiver, right? So they're typically unpaid, and the majority of dementia care in the United States, and that costs us billions of dollars a year in the United States, is unpaid care. And that's care that's provided by family members at home. So spouses, partners, adult children, and that we consider to be informal, right? So formal would be you're paid. So these are people through home health agencies, certified nursing assistants, and you might have some specific training in caregiving in terms of toileting, feeding, potentially, administering medications. And that type of care can happen either in the home or in a skilled nursing facility or assisted living environment. So some advocates in the dementia community have been pushing forward the word care partner as opposed to caregiver as a way to support the dignity of the person living with dementia. So we don't want to think of the person living with dementia as a passive recipient of care. So I'm going to give this to you, but rather the other individual is partnering with that person living with dementia, despite the challenges that that person is living with, in order to get the best care possible.
And that term care partner, it also, I don't know, I'm sitting here reflecting on it and interpreting it. It also makes me think of a bi-directional relationship. So basically implying that the caregiver or care partner is also experiencing components of dementia because dementia has such a big impact on the entire family. Would you say that that's an accurate reflection?
Absolutely. And there are a host of interventions that are designed just for care partners to release some of that caregiver burden. And that's anything from support to more directed psychosocial interventions, because dementia does not just affect that person, it affects the whole family system. One thing that illustrates this
idea is, maybe you have adult children who are caring for the person living with dementia, and maybe they're taking turns, and we find this quite a bit, and they're making certain decisions, in regards to the person living with dementia, their health, their environment. But then you might have an out of town son or daughter come in for a visit, and they come in and want to switch the care plan completely. And then it can result in really difficult conversations among the adult children. And there's really just a lot of complexity in terms of how dementia impacts not just the person living with it, but the whole family, friends, everyone, formal care partners, if you're in a setting where you have a formal care partner as well.
This makes a lot of sense in terms of the level of complexity of how dementia impacts so many stakeholders in a family, formal and informal. And I'm wondering how, I'm just looking at our learning objectives and reflecting on this complex problem. How does this relate to implementation practice and implementation science?
Right. So if you think about implementation science as the science or the study of which strategies or techniques can support the uptake of evidence based practice in a typical setting, implementation science is really focused upon what do I need to do to get a practice into the real world. And that has scientific inquiry along with it. So you would kind of follow the scientific method in terms of this strategy might be superior to this strategy. Whereas implementation practice is something that I've really only learned about in the past couple of years. And implementation practice, you can think of it more as the art of what we do. So as speech language pathologists, this is what we're doing all the time, right? We are very skilled at kind of mixing that art and science in thinking about, I know the specific evidence-based or best practice that I want to implement, but what's more, some people might refer to it as like soft skills, right? What are the things that I need to do to really make that happen? And we're doing that all the time as SLPs.
We're constantly juggling that line between the science or the internal evidence and then the realities of clinical practice. And so one of the resources that they put out, these folks who are studying and really exploring implementation practice, they have 6 principles that kind of underlie implementation practice. So I don't know, or 6 domains, if you will. I don't know if we want to go over all of them or not, but I can just give you a rundown.
Give us a snapshot, because I'm very unfamiliar with this term. So
I'm very interested.
Go for it.
So the first principle is being empathetic. Hello. We already know about that. Mm-hmm. Being curious, being committed, advancing equity, using critical thinking, and embracing cross-disciplinary approaches. And like, none of these things are new.
I love this.
They're all things that we do as clinicians all the time. But I think to see it laid out with this implementation lens, it is extremely helpful. But one of the main aspects of this is you co-create and engage from the beginning in order to sustain change. Okay, so this is less of a top down, I have this information and I need to, from on high, put it down onto you, right? But it's more of a, we're all in this situation learning together, and we're kind of co-designing, yes, informed by evidence and the science, but we're also tailoring this to the context, if that makes sense. And we're making those necessary modifications.
And can I say this back to you in case, just as like to help digest that? Because I think what you said was so obvious and something that we all do, but also it sounds like it's a little bit more complicated than that. And it sounds a little bit like a framework for how to go about implementing science or implementing
Right.
your knowledge. And I know Amy and I, we both love a good framework, but it helps give a little bit of structure to what you might already be doing. And when something has structure, you have footholds to implement it better or implement additional components that you might have overlooked. Is that the right sort of landscape?
It really is. It really is. So how they have it listed, Metz and colleagues, it's called the Implementation Support Practitioner Profile.
And we'll link this in the show notes for anybody who's out there running, driving, or what have you. All of this will be in there.
Awesome. And so if you're guided by these principles of empathy, curiosity, commitment, critical thinking, equity, and cross-disciplinary approaches, it suggests that we co-create and engage, that we participate in ongoing improvement. So it's not a situation where we're like, okay, here it is, boom, we're done, sign off, right? But we're continuously monitoring either the client or the practice or whatever it is. And we're continually making these tweaks, knowing that we work with human beings within human systems. And so that's constantly going to require adaptation and change. And then it gives some suggestions for sustaining change, right? So it's like, now that we maybe have seen this change happen, how do we do it? And no shocker to the two of you, I'm sure, the main way that you do that is through growing and sustaining relationships, right? And so I think when it comes to dementia care, I've found this so, illuminating, because it's like nothing works in training any care partner without the foundation of that relationship, right? And so, yeah.
I also just want to highlight that the first component here is empathy. I mean, that really just reframes your knowledge to be focused on person-centered care, client-centered care, considering client and family stakeholders and values, and making that connection with them. And that's the first thing on this list, which is really wonderful. And just as a reminder to everybody listening, client perspectives and values are part of our evidence-based practice model. We often get really hung up on evidence being a research article or this component of external evidence. And yes, that's important, but considering client, the patients, and values is also creating an evidence-based practice environment. So I love that that's listed first, because I think we as a field tend to lose sight of that sometimes and really get really hung up on our knowledge, on our external knowledge.
Mm-hmm.
Yeah, I agree with your take on that completely. And I think it also highlights, first of all, I'm like ready to go out and read these things, because this sounds like something that
I can hear you furiously taking notes.
I know. I'm like, don't open the article in the middle of the recording. But I do, I think it's sometimes we get a little tricked in feeling that like we know the one best right answer for other people. And Natalie, I feel like you did a really nice job just talking about how that's actually a conversation, and the one best answer isn't something that you can just duplicate and apply out to all of your clients who present as XYZ, because they're part of a human system. I think called a human family system. And we all are. And, having the empathy, like you were saying, Kate, being curious about your client and their care partners and what their values are, is going to help us provide more meaningful and probably more effective therapy.
Mm-hmm. Yeah, absolutely. And I think that I learned that as a practicing clinician, just feeling very burnt out and sad, and like I wasn't really helping anyone. And part of the situation was I was working PRN, and I think a lot of people work PRN in skilled nursing facilities because it works really well with the schedule. And but I would come in, I would pick my kids up from school, and then I would like get them situated and go in for a few hours and then be done. And being there for those like 3 or 4 hours, I wasn't able to build the relationships that I needed to anything that I wanted to implement. It was just extremely challenging to build that without those relationships. And it was hard for me to provide a communication strategy, if you will, or a memory support if I didn't know, okay, what's this person like during the day? What is the nursing assistant's take on this? What is the most burdensome communication breakdown for them? And those things were kind of absent. And I think sometimes that can be a really big challenge when we're thinking about people with dementia if we don't have a picture of what's going on all day. And I'd imagine it's probably pretty similar with a school caseload too.
Yeah, I mean, I think no matter where we as SLPs work, that, workplace barriers and time restrictions are always a thing in terms of, how we communicate with our colleagues, but also having access to families, having access to home life, having access to and time built into our schedules for consulting with the families. I have to imagine that counseling is also a massive piece of working. Right. I've never worked with an individual with dementia, but, counseling families who are grieving, who are going through this incredibly complex, challenging time, arguing with their brother in Idaho who made these decisions when they were here for Christmas or whatever. I mean, there's a lot to unpack in these very complex situations. And, we've said it on this podcast 1,000 times before. We don't necessarily get training in counseling. We don't necessarily have funding for indirect service. Most work settings don't have indirect service as a norm or even built in as an option. So in everything that you're saying in terms of the skilled nursing facilities and the PRN schedules, those are massive barriers to be able to adequately support these families if some of the first things we need to do are establish relationships.
So to piggyback on that point, how do you integrate those elements of implementation practice, and how might that change the way your training of the care partner looks? So the difference kind of between training without integrating those components versus kind of a more informed approach to care partner training.
Right. And so I can answer the latter part in thinking about what I had to do, which was a lot of handouts, a lot of do this, a lot of we need to, do this type of strategy, kind of catching the nursing assistant, wherever they were and trying to, when they're obviously still so busy and overworked. And we're actually recruiting for a study right now where we're trying to study if there's a way to do this. So we're therapists speech paths who are working at Encore Rehab. So we're have a partnership with them where we're looking at, I have a kind of dementia care partner training CNA certified nursing assistant program that we piloted. But in this new iteration, we're trying to layer in some of these principles of implementation practice to see if that matters, if it makes a difference. And to see, probably more importantly, is this an acceptable and feasible thing to do on the clock, when you're working?
So is that an example of implementation science right there?
Yeah. It is. I mean, it's not done. We're trying to do it, but I think the partnership, right, is part of implementation science, the collecting the data in the real world and having so in some care partner training studies, what they'll do, and, it's legitimate, is you have an interventionist come in, right? So you have like a special research employee of the grant, that's funded by a grant, and they deliver the intervention. So in this scenario, it's the person that's already working that's having to balance all of these situations. And it's a mixed method study. So, if the SLP is like, I can't do this, the study isn't over. It's okay, got it. Why? Why can't you do this? Tell me what's going on. Let's try to problem solve this. And I'm hoping that we're going to learn a lot.
That sounds incredibly interesting and also like a lot of work. So hats off to you for taking on such a robust project. I'm thinking about our second learning objective and an evidence-based practice approaches to managing communication. But before we get there, to sort of set the stage, I wonder if you could just talk to us generally a little bit about components of supporting quality of life and communication for persons with dementia.
Right. So I think a person living with dementia, like every human being, they want a reason to get up in the morning. They want to have purpose and engagement. They don't necessarily, do you want to go play bingo every day? Right.
Maybe. That was a rhetorical question and not very helpful. I apologize. I see your point. I do not want to go play bingo every day.
Right. But if that's your own, or to listen to a person with questionable talent sing in the hall, You know
what I'm thinking of? I'm thinking of in elementary school, we had to go sing at the nursing home a couple times a year. It was our
questionable talent.
It was my questionable talent. It's me you're talking about, isn't it? They don't want to come and hear me sing, or my kids. But to your point, you're right. They're human. Right. They're still human beings and they have interests.
Right, exactly. So I think one of the ways that we can best support, and this is supported in the literature as well, is to really get to know the person and to figure out what makes them tick. And if it's not something that maybe is within their wheelhouse right now, what is it that they used to love to talk about? What is it that they used to do? And what can we do to modify that or to set up the environment in a way so that can be supported? So one example I can give is I have a student, and part of what they work on for these are undergraduates, is they are communicating with someone with dementia a couple of hours a week as part of a service learning course. And so the student came and she was like, I can't get this person to talk. It was a person, in their 80s in a nursing home with Alzheimer's dementia. And she's like, he just kind of sat there and was kind of awkward. And, so I'm like, well, what, is there anything about him that and so sometimes that can be hard, as you talked about access to family and access to interests, but she happened to see something that had the Detroit Tigers on it. And so I'm like, what about making, a memory book of just some famous Detroit Tigers players and some photos? And I'm like, I have no idea who the Tigers players are, but, so she went in, she just had some type of external item that they could kind of go through, and it's like, oh look, it's a baseball, it's having that communication support, and you guys know all about this is your area, right? We can do that in a very low tech way, but it has to be something that the person cares about. It can't be a random conversation topic, so I think by cultivating interests based on the person, that can really support quality of life and communication. And then the other thing is giving someone a meaningful role. And so we even try to do this in skilled nursing environments. And a lot of this comes from the Montessori for aging and dementia approach. So you might have heard of Montessori for kids, but there's a whole study of Montessori for people with dementia and aging, where it's, maybe I used to love to, maybe I was I worked at home. So now we're going to have that person fold the towels, in the long-term care community, and that's going to be her role. Maybe I love to talk to people, but I can't remember anything. Well, I'm going to go pass the mail out to people, right? And that's going to be my role. So we can find ways to support engagement that's really authentic and not kind of a contrived activity, if that makes sense.
I love the word authentic. I love it. I think it nails exactly what it is you're trying to do, because there are components of what I think sometimes feel we have to do in therapy that are so contrived.
Right.
And that we do our best to make them fun, right? We do our best to be engaging, but it's exactly what Amy said before. It's not for us to decide. It's for the person to decide. And I know that can be tricky when you're working with someone who has a communication disorder, but that's your job, is to find something that's authentically enjoyable. And I think that's the best adjective that you could use there. No question.
Yeah. Yeah, we got to keep it real. They know. I mean, you might lose your memory and you lose skills, but when things feel yucky, right?
Mm-hmm.
And people with dementia, they don't want to be quizzed or, feel like they're taking a test, or feel bad about themselves. And sometimes these, more impairment-based activities can do just that with good intentions, but there are better things that we can do, I think.
So go ahead, Em.
I was just going to say that from a quality of life standpoint, nobody wants to feel like they're failing a quiz all of the time. So it makes sense that if your therapy activities are too deficit focused and it seems like you're making your client feel badly, you should probably pause and rethink how to do things a little differently.
Yeah.
So as the implementation science expert, I'm gonna give you the crown. You're the queen of implementation science here at Nerdcast Central. For all of the PRN SLPs who are listening, who have these realistic workplace barriers, who are there for only a small number of hours a week, what are some practical things that they may be able to do within their workplace restrictions to make these connections, to, implement some of these evidence-based ways and overcome the hurdles that the job just inherently has?
Right. I love that question so much. And I think the first thing I would say is recognize that you are working in a broken system and you are doing the best that you can. And this is not about a failure on your part. It's just not. Like, the restrictions that you're experiencing in terms of time and productivity, it's not your fault, and I think, it's an impossible system to work in a lot of ways, so practically speaking, I would consider it skilled therapy time to interview that person and get to know them, because not everybody can do that, right? That takes the skills of a speech language pathologist to dive in deeper and you can call it dynamic assessment, you can call it informal assessment, but using your skills as an SLP to really deep dive into who that person is. And I would also use your skilled billable time to make those memory aids and supports in the presence of the person with the person.
Love that idea.
Yeah, that's not my idea. So this is Becky Kayam's idea with Memory Core and Cognitive Concierge. And she's one of our, she's a colleague and a friend of mine. And she's like, because productivity is a major issue, especially in skilled nursing facilities. Mm-hmm. And so it's a skilled service, right? Because maybe you're getting personal information and you're using that to tweak your external memory aid or your communication support, right? And so you're trying it out. And one of the things that she recommends, if you don't have a huge budget, which not many people in SNFs do, is to ask your rehab manager to get one of those portable laminators. They're only like $50. And then, with all the other equipment that PT and OT have, it's a pretty reasonable request. And then you can print and make some memory aids and trial them out, as part of your session. So that might be some practical tips that I hope, might facilitate that.
So in talking about these memory aids, I feel like you're leading us right into our second learning objective, talking about some case studies that highlight evidence-based practice approaches to manage communication and life participation. So I don't know if are there other evidence-based approaches that we should be aware of?
Right. So I think that, external memory aids and supports, we have the most evidence for that, in terms of dementia. I think another really high impact, high evidence practice is environmental modifications. So what can I do to make the environment more conducive to communication? So this might look like simplifying the environment in terms of not making it too cluttery. If you have an external memory aid, a lot of what we do in some of the buildings where we're implementing Montessori is we'll put the external memory aid in a frame. So it'll say like, please enjoy the music, right? And like, it'll be like a memory aid that says that right next to some type of music player, right? So they might be, oh, look at this. And it might be new every time, and we don't expect the person to remember that. But if it's a designed memory aid that is clear, they're going to get that cue, getting rid of clutter, labeling the toothpaste, labeling the soap, not having a bunch of like, different tchotchkes in various places, so that things are nice and clean. One of the things that we did in a community that we were working in was there was this beautiful bay window, and one of the people with dementia, she loved to look outside. There was like a birdhouse, and it was so nice. And wouldn't you know, somebody went and brought in this like nasty fake plant, and it like took up the whole window, right?
Bummer.
And I'm like, I know,
Who
right?
did that?
I don't know, but I took it and I put it in my car.
The plant thief. That's amazing. It was the brother from Idaho, wasn't it? That's who it was. That's who it was.
Right. But it's like,
sorry to all of you in Idaho. Nothing
sorry,
against
Idaho. Yeah, but it's like when you think about setting the environment up for communication, her looking at the birds and looking at the flowers outside, that's an opportunity for communication, right? And so having that blocked, and then we would even put a cue there that says, please enjoy looking outside. Oh, that's right. I love to look outside. I love to watch these birds. So I think external memory aids, the environment, training communication partners and care partners, and also instructional techniques such as errorless learning and spaced retrieval training can really support outcomes related to safety, related to even swallowing strategies that a person with dementia might have, and other kind of key pieces to support engagement.
What's a spaced retrieval strategy?
Oh, good. I was hoping you would ask that. So if you Google Health Professions Press spaced retrieval training, there's a little 4-minute video that Jennifer Brush and Jeanette Benigos and Gail Elliott made as a companion to the resource spaced retrieval training step by step.
Interesting.
Which
Okay.
it's essentially you capitalize on the preserved procedural memory of a person with dementia. And this means I might not be able to tell you with my words how to make a cup of coffee, but if you put the coffee filters, the coffee in the pot, and coffee was something that I made every morning, there's a very good chance I can just walk up to the coffee and start doing it, right? Now, what spaced retrieval will do is it targets one specific area of interest. So I'll give the example of if you wanted to train someone to use a call button before they got up out of their bed, if you wanted them to call the nurse with the button instead of just getting up because maybe they're at risk for falling, okay? So if I were to do spaced retrieval, I'd say, hey, Kate, what do you want to do? What do you do when you get out of bed? And then I would say, you hit the call button, okay? And then I would maybe take your hand and I would show you the call button and you would hit the call button, right? And then like 1 second later, I would say, hey, Kate, what do you do when you want to get out of bed? You hit the call button, right? And so then you would say, I hit the call button while you're hitting the call button, okay? If you weren't able to answer me right away, then after a few times, I might say, okay, Kate's not really a candidate for spaced retrieval training. It's almost like a built-in screen.
Mm-hmm.
But if you were successful and you repeated me and you were able to do the action right away, I would wait 2 seconds and then I would ask you again.
Mm-hmm.
And then if you were successful, I would wait 4 seconds and then I would ask you again. And you can kind of go all the way up to like 15 minutes to where ideally I might go and see some other clients and then come back a few hours later and say, hey, Kate, what do you do when you want to get out of bed? I hit the call button, right?
There you go.
So it's one of those things where it's the opposite of what we think of with our typical speech therapy services, in that we shouldn't expect it to generalize to other topics. Okay. So it's very situation specific. So if you want to train something using spaced retrieval, you only do it one at a time until that information is learned.
And in this example that you gave us, it involves a motor movement. Does it always involve a motor movement, or could it be used for something else?
Yes. So there have been studies where it's used for other things, like, important names, names of loved ones, things of that nature. In my experience, I find that it is much more effective when you have a motor movement. The other way that we use spaced retrieval is as an instructional technique to attend to an external memory aid. So a lot of times people will say, I put up signs, I put up cues, and they don't look at them. Well, that's part of our skill set as well, right? We have to train them how to use it. So it's like, what do you do when you want to know the schedule for the day? I look at my calendar. What do you do when you want to know the schedule for the day? I look at my calendar, right? So you can use it. I think it's more effective, especially in people with dementia, when you're pairing it with a motor movement or when you're referring to some other type of support, like a memory aid.
That makes a lot of sense. Just that interaction between the environment, the movement, making it a multi-sensory, multifaceted learning experience. I mean, we know from so many components of literature that's a critical component of learning, is making it more dynamic, engaging, all of those things. So that makes a lot of sense. Are there any other evidence-based practice approaches that you want to go over before we start talking about SLPs as key members of teams?
I think if you think about, if we come at this from a person-centered lens, and then we're thinking about creating, from our instructional perspective, like the instructional techniques that we use in people with dementia, it really should be errorless learning. And like, if the person is making a mistake at all, even once, we got to back up and do something else. Like, it has to be totally successful, because people with dementia are going to continue to lose cognitive function. And so it's not a situation where it's like, okay, my goal is to stop this person from using cues, right? Like, you want them to use every possible cue. And so if a person is making mistakes or not getting it, then we need to switch what we're doing or add more supports or something like that. So I think thinking about person-centeredness, external supports, an environment that supports communication and meaningful engagement, I think those, that will go a long way.
In my mind, you just painted a Venn diagram with these three circles, and sort of like living somewhere in the middle of those, depending on patient-specific variables and idiosyncratic changes that need to happen and stuff. That was very eloquent.
Yay. You're just very kind. Did not feel eloquent coming out, I'll tell you that.
Well, considering I started this episode talking about how I wasn't going to scream scurvy in your face, I'm glad I've upped my game since the last time you were here. So let's think about, I want to sort of paint a broader strokes picture really quickly. So we're thinking about SLPs who might be listening, working as in a PRN capacity with numerous hurdles to implementing some of these things, needing to have a focus on person-centered care, considering these components of implementation practice. I think that the workplace setting, as we have said multiple times, is such a real barrier. And I think your third learning objective really starts to get at that in terms of workplace settings and the team that you work on, and how the SLP can, knowing this information that we've gone over, really advocate to become a key member of the healthcare team, and how that might impact some of this work you're talking about. I wonder if you could tell us a little bit more about that.
Right. I think that by finding out, what are the pain points of other people who are working within the community. So, for example, what is the physical therapist trying to get the person with dementia to do? Right. And so maybe we can do a memory support for hip precautions or fall precautions. Maybe we can use spaced retrieval to train the person to lock their wheelchair brakes before they get up, if that's a goal that the physical therapist has. Or, what is occupational therapy doing? What activities are they wheeling them down to? What are the activities assistant, what are they taking them to, and how engaged are they? So is there something that we can do that's kind of within the routine or the program of events of that person that we can help support, right? So we're kind of showing our value by saying, okay, look, they were just coming to activities and they were just sleeping the whole time, but yet we could say that they were in the activities room, when really there's a way that we could support that. What is a pain point for the nursing assistant? Is it getting dressed every day? Is it eating? Is it something that happens at night, right? So I think by inquiring about what's hard from other staff members can really show our value, because we can make it easier for everybody. Because I think with people with dementia, the fundamental problem is the lack of ability to communicate, right? And so when we have these things that people call behaviors, right? They're really responses, right? They're attempts to communicate, right? So when Mrs. Smith starts screaming in the hallway and crying, how can we attend to the emotion that's underneath that and validate where she's at and support, right? So I think that a lot of times we're tempted in that setting to kind of just go in and get our minutes and get out. I mean, that's what I did in a lot of cases. So there's absolutely no judgment there. But I think if there's any way that we can get the bigger picture and make our plan of care somehow related to other aspects of the person's care, it can really show the value, like when we can open up communication for someone who's really struggling.
You know what? Something that you just said reminded me of, we had Dr. David Luderman on as a guest a ways back. And for anybody who's listening, who hasn't listened to that episode, it's on counseling. And he talked about responding to the subtle knocking. So what is the underlying emotion? What's the underlying feeling? And responding to that instead of the screaming, instead of the crying, and trying to lead with empathy and respond to that subtle knocking. And I think he credited that to maybe Carl Rogers. I can't remember off the top of my head, but references there. And I think it's such great advice.
Yeah, I was going to tell you that I had my counseling students this summer. That's how we started the first day of counseling class, was listening to that podcast.
Awesome.
So great to hear. He's amazing.
Yeah.
It was awesome.
I was there for that. I was there for that interview, and I've listened to it like 3 or 4 times.
Yep.
I made my husband listen to it. I mean,
Yep.
he's just so influential.
Oh gosh, he's so dang wise.
I know.
Yes.
Anyway, this is the first time we've gushed about a previous episode on a current episode. So that's a first. It's always exciting with you, Natalie. But but responding to that pain.
What's underneath? Right.
Exactly.
Right.
It's that subtle knocking. And for anyone who doesn't feel like they have that in their skill set or wants to learn more about counseling, we all encourage you to do it. It's a key component of what we do as SLPs, and we just don't get enough training on it, unfortunately.
And I feel like, just to cycle back to the first learning objective, that's also got to make a difference in our clients' quality of life.
Absolutely. Absolutely. And I think one of the things that implementation practice has really challenged me on is trying to engage with direct care providers. So in this case, it would be certified nursing assistants. How do I engage with them in a way that is authentic and meaningful and real? So we already have a huge pay gap between what an SLP is making and what a certified nursing assistant is making. They're there, cleaning up puke and blood and wiping butts. And we're seeing the person for maybe 30 minutes, right? There's already some perceived imbalance there. And so how do we kind of enter into what the nursing assistant has to do and engage in a way that would be meaningful to the nursing assistant and the person with dementia and to us? Because then we can see that we're really making a measurable difference.
I feel like this is related to another topic that's come up recently here, related to something totally unrelated to SNFs, but that's bringing humanity back into therapy.
Oh yeah.
So being a person, showing up at work as a person, trying to make those connections with your colleagues, trying to make those connections with your patients when you can. And I mean, to your point, we've all just shown up at work just to get the hell out of there. I mean, that's part of being a human, and there's no judgment there at all. Right. But I think when you're a clinician working in environments where there is grief and there is pain and there is vomit or blood or something that is, evokes an emotional reaction, it's impossible to just clock in and clock out every day. There is some component of humanity that we need to embrace in our clinical work to improve the lives of our coworkers, our patients, and establish. I love how you've wrapped this up in establishing us as key members of the team, because there are workplace politics involved in humanity too, which is crazy.
Right.
We don't think of it that way, but it's true.
It really is true. And I will never forget, one of the biggest learning experiences for me was I was working with a nursing assistant, and it was hard to connect. And sometimes it's hard. Sometimes it's hard to connect with other humans. And, I was asking her, if she could use this communication strategy. And I think the person had swallowing strategies, and she was just kind of like, yeah. And I don't know how the topic came up, but there was a lice outbreak. Okay. And like, my kid had lice, her kid had lice. Somehow that came up. And I'm telling you, the moment of connection was so real. And it just was able to dissolve all the barriers between us. And I know that all three of us, the person with dementia, her, me, we all had a better day. We had a better outcome over this horrific thing that I hope never comes in my house again. But it was that humanity moment that you speak of.
Mm-hmm. But hopefully folks will find something a little less intense than lice.
Little less invasive. I mean, you guys can't see my hair. Yeah, I have a lot of hair and it's curly, and it's just like a lice field day in there.
Oh my God. I mean, but really, we talk about this as part of interprofessional collaboration that ASHA has really embraced. So, having a focus on interprofessional education, interprofessional partnerships, it's something that's defined by the World Health Organization. It's something that's very real. It's not just making buddy with your coworkers. I had a mentee say to me one time, but I don't want to be friends with them. I don't want to be friends with this person. And I had to sort of back up the train and highlight that this isn't about friendship. This is about positive working relationships and being, showing up with professional maturity, showing up with humility, and being a person and not a jerk. And everybody's allowed to be a jerk sometimes. I definitely am sometimes. It's a thing. And I again, to bring this back to your learning objective, when I love that you did this, I think this is so brilliant, is that when you do that, when you embrace these qualities, your work environment, it will improve. There will be a ripple effect there. It's not just to be, hokey pokey with everybody and sit around and give each other hugs all day long. There are actual realistic and logistical positive outcomes that will come from embracing this kind of team environment and person-centered, and humanity-centered care.
Right. I think so. I really think so.
Well, I think so too.
Are there any other strategies beyond being a human, being a friendly person, trying to actually identify the barriers for your colleagues and coworkers and work to support your client through navigating those barriers? Like, I'm thinking, as someone who does partner training type tasks, is there also this piece of be cognizant of how much work you're asking other people to do, or any other?
So much yes, Amy. Yes. Like, so one example that we use a lot in training our students and other, clinical fellows is I personally, I have learned that I don't want to give a nursing assistant something else to do unless I'm willing to take something off of their plate. So sometimes I will say, sometimes I'm a big advocate for cross-training of everybody in the building when we're talking about a skilled nursing facility, so that everybody can take people to the bathroom, everybody can take, the transfer with supports. And of course there's training that's required to do that. But if maybe I can go take this trash out. Maybe I can help make the bed, even if I'm not trained, so that you can do this, right? So it is more reciprocal. So not putting on the burden of more work unless we can take something back, because it's just not feasible to add more to someone's workload.
And I almost wonder if that helps with the relationship piece, because it breaks down some of those kind of hierarchical pieces too, of like, well, I don't do transfers. I don't know.
That's right.
I don't.
Exactly. And I know some people are constrained because like they're not trained and they're truly not allowed to do transfers or, bathroom, different
Safety first,
different rules. Yes.
Safety first, for sure.
But if you can, even if it's not a transfer or a bathroom, if it's a little thing like passing a tray, or something that doesn't require training, to kind of show
camaraderie.
Investment. Yes, exactly.
Yeah.
Or like you could ask about training, perhaps, depending upon your work environment, depending upon the management. Like it doesn't.
That's right.
Just because something that's there that requires training doesn't mean you couldn't ask about the training, because we're sort of asking everybody else.
That's right.
To want our training.
That's right.
That's exactly right. How completely condescending of us to expect other people to get our training if we're not going to help you make the bed. That's not very nice.
Mm-mm. Mm-hmm.
So in our last minute, I'm just thinking of people who might be listening in these positions who have like listened to all of this information over the last hour. Do you have any advice, any, parting words of wisdom or advice for clinicians who either want to learn more about implementation practice or want to acquire more knowledge in this area, or anything?
My biggest piece of advice is probably to continue to care for yourself if you can. This is such a high need, it takes so much. It requires so much. And if you can care for yourself, and it's just so critical. And I am so happy to, there's a community of people that are really passionate about improving dementia care in these settings. And if there's anything that any of us can do, I hope that you really will reach out. Of course, there's books and articles and blah, blah, blah. But not that those are bad, but if you want to brainstorm something, we're here. This is what we do. But, recognizing the work that you're doing and caring for yourself.
That was really good parting words. I don't think I can follow anything up. I don't think I can follow that. Aim.
No, it was good. If we don't take care of ourselves, we burn out, and there's no one to do any of the helping.
Mm-hmm.
Thank you so much for being here today. You're just so full of wisdom, and we learn so much from you every time you're here. So thank you so much for being here and for your time and all that stuff.
Well, I'm so grateful to be here with all of you.
Oh,
there's only 2 of you, but
there's so many people listening though, right?
Yes.
We hope. For all of the things that we talked about today, there will be links in the show notes. So if you're driving, running, everything will be written down. There are references, resources, and links. There's also a link in your podcast player to earn ASHA CEUs if you so choose. Thanks everybody for being here, and we hope everybody learned something.
Bye. Thank you.
Thank you so much for joining us in today's episode. As always, you can use this episode for ASHA CEUs. You can also potentially use this episode for other credits depending on the regulations of your governing body. To determine if this episode will count towards professional development in your area of study, please check in with your governing bodies, or you can go to our website, www.slpnerdcast.com. All of the references and information listed throughout the course of the episode will be listed in the show notes. And as always, if you have any questions, please email us at info@slpnerdcast.com. Thank you so much for joining us, and we hope to welcome you back here again soon. Another big thank you to our corporate sponsors, MedTravelers, who helped make this episode possible. Our corporate sponsors keep our CEU prices low and our program ad-free. MedTravelers is your industry leader for exclusive allied healthcare travel opportunities. MedTravelers has benefits like higher earning potential, W-2 employee status, and a flexible schedule. Visit medtravelers.com to learn more. MedTravelers did not participate in creating the contents of this episode.